Chairperson and respected audience, Assalamu alaikum and very good afternoon. I'm Dr. Samia Tasneem, registered cardiologist from the National Institute of Cardiovascular Disease. Today I'm going to present a case who was a 54-year gentleman, diabetic, ex-smoker, presented to us with angina and shortness of breath for 1 year. He had a history of inferior MI when coronary angiography was done and revealed double facial disease with left main coronary 70% distal stenosis, LED 80% proximal stenosis, and there was 100% distal stenosis at the RCA. So he was advised CAP-based at the time but denied and subsequently went for PCI when drug-eluting stent was done in the left main coronary artery and the LAD. RCA CTO was tried at the time but failed. With that, when he presented to us, his echo showed 40% ejection fraction. So with that, we took the patient for angiography, and you can see here at LAD, there is patent stent from both in the left main coronary artery and in the LAD. There is also a new lesion, 80% osteal lesion at the L6. However, the vessel is narrow, and it was non-dominant. At the right coronary artery, however, there remains the RCA 100% stenosis. So to ensure the viability of the chronically stenosed RCA territory, the MPI was done, which revealed reversible perfusion defect at the RCA territory. So we planned for RCA CTO PCI according to the European Vascularization Guideline. And for that, for planning of any CTO procedure, angiographic scoring is very important. And the most widely used is JCTO score, which actually consider 5 parameters and each allotted for 1 point. But as the score raises, so declines the success rate. And at the same time, the wire crossing time also increases. We also considered the distal vessel target and interventional collaterals for consideration as part of the hybrid algorithm. So if we consider our patient, the proximal stump was tapered with a side branch. There wasn't any obvious calcification. Bending was less than 45 degrees with 20 millimeter length, more than 20 millimeter length, and failed previous attempt. So the JCTO score for this patient was 2, and this was a difficult case. So considering all this, we planned that we would go for antegrade approach, and if this failed, we would go for retrograde approach because there is some septal collaterals supplying to the distal RCA from the LAD. So we established double access. It was bifemoral access, and took Judkins right 3.57 French guiding catheter to the right system, and Judkins left 6 French diagnostic catheter to the left system for contralateral injection and visualization of the distal flow beyond the CTO segment. At first, we tried with Fielder XTA wire, which is a polymer jacketed wire, with the hope that maybe it would pass through the microchannels and traverse the CTO segment, but we failed, and it seemed that although it wasn't obvious, there was much calcification and the lesion was quite stiff. So we escalated to Confiance the Pro 9 wire, a stiffer wire, and it successfully pierced the proximal cap. After that, we traversed the CTO and almost went to the distal part, but it failed to reach to the distal true lumen. At that point, we aborted the antegrade strategy and went for retrograde strategy. So for that, we engaged the LAD with XB 3.57 French guiding catheter and instead commenced the retrograde strategy with septal crossing with microcatheter that was Corsair in this case and Sion wire. So we planned for contemporary reverse card because the advantage was that it allowed minimum dissection to the subintimal space. So we inflated antegradely a 2 into 15 millimeter small balloon and tried to aim the balloon with retrograde Gaia second wire. But the Gaia second wire failed to pierce the plaque, and we escalated rapidly to the Gaia third wire. Even though it was failing and it wasn't getting any nearer to the antegrade balloon, so we escalated further to Confiance the Pro 9 and aimed the balloon, although it pierced the heart plug, but we couldn't connect the proximal and retrograde dissection plane. So we pulled the balloon, inflated, and tried to bring the retrograde Confiance the Pro 9 wire at the same antegrade dissection plane created by balloon inflation and confirmed the placement of 2 wire by rotational angiography. After confirming that, we took a bigger balloon to create plaque dissection and provided a target space for retrograde wire penetration into true lumen. Even then, the retrograde wire failed. So we de-escalated and took slippery filter XTR wire maneuvered successfully to reach antegrade RCA guiding catheter. The rest of the steps were quite easy. We trapped the retrograde wire in RCA guiding catheter and then took the retrograde microcatheter in antegrade RCA guiding catheter, then took out the retrograde filter XTR wire and exchanged it for RG300 wire. Then we externalized the wire through the antegrade RCA guiding catheter. You can see here the retrograde RG3 wire externalized, and subsequently over that wire we placed 2.75 into 48 millimeter drug-eluting stent.
We can discuss.
Okay, we can discuss
Samia,
the presentation.
finally you have succeeded through the retrograde way.
Yes, sir. Retrograde way.
So
I was planning to show the final view.
Anyway, you have succeeded through retrograde way.
Yes.
Which, do you know the name of this procedure?
Yes, contemporary reverse cut.
Reverse cut.
But it is the slight modification of the traditional reverse cut, because in reverse cut we actually put the antegrade wire to the proximal part of the CTO. But in contemporary reverse cut, we put it to the distal part. Don't cross the CTO body, but put it in the distal part and inflate a balloon and targeted it with the retrograde wire, because in that way it allows minimal dissection and precise pointing towards where we are going.
Okay, just complete your presentation.
So here you can see the externalization of the RG3 wire, and we took a balloon over the RG3 wire for lesion preparation. Then here is the stent deployment. We deployed 2.75 into 48 millimeter drug-eluting stent. Okay, so the final view was that we established the TIMI3 flow in the RCA, and it was quite rewarding in a sense that instantly it alleviated the patient anginal pain. So for any CTO PCI, so we deployed here the stent, post-dilatation was done. And before removing the retrograde catheter, we checked the septal branch for any perforation by antegrade injection. So this was the final result, with TIMI3 flow established distally beyond the CTO segment. So in conclusion, I would like to say that guide crossing is the most important in CTO PCI, and we need to always have a backup plan. And all CTO procedure requires endless delicacy and patience, but it's rewarding because it removes the patient's anginal symptom and also it improves the quality of life. So thank you for your kind attention. Sorry for the technical glitch,
Samia.
and thanks in advance